Good afternoon. I'm Dr. Manchikanti. I'm the chairman of the board of American Society of Interventional Pain Physicians. I'm speaking on behalf of Dr. Bryce. I do not have any conflicts of interest. The FDA launched a Safe Use Initiative on November 4th, 2009. Since then, it has gone through several phases. The Safe Use Initiative rejected 20 recommendations, which are essentially the standards of International Spine Intervention Society. Even then, the FDA made safety and efficacy announcement in April 2014. Following this, the Multi-Society Pain Work Group approved 17 recommendations. We have major concerns in reference to the evidence standards applied here. The Institute of Medicine has developed 8 standards to be followed in the development of guidelines. In fact, studies show that majority of the clinical practice guidelines have not followed these 8 IOM standards, and IOM itself followed only 2 of the 8 standards and failed to follow 4 of the 8 standards. This is also evident with misrepresentation of evidence on chronic pain. We keep quoting that prevalence is 100 million and it costs about 635 billion. However, this estimation includes the joint pain, arthritis, and functional disability leading to that high number. Moderate and severe pain is only approximately 21%, costing about $100 billion. This is a large number, of course. There are multiple risks and complications associated with some of these procedures, as we have seen. Specifically, cervical transforaminals are associated with a high risk with no efficacy. However, we are translating all the information from cervical transforaminal epidurals to everything else. In contrast, lumbar transforaminals are associated with moderate risk but with efficacy. Cervical, thoracic, and lumbar interlaminars, as well as caudal epidurals, are associated with low risk with efficacy. Multiple studies, including the one by ICES, following their own standards, have shown a very low complication rate of 0.1%. However, without following ICES standards, we have shown a 0% complication rate in 150,000 patients. The mechanism of injury of complications with transforaminal epidural injections probably is misinterpreted. It has always been stated that embolism of the particulate steroid is responsible. However, as we have seen from the data, a similar proportion of complications also have been reported with non-particulate steroids. Consequently, the argument about the use of non-particulate steroid may lead to false sense of confidence without increasing safety. Now, as we have seen, it is impossible or extremely difficult to avoid complications in the cervical region, whereas in lumbar region, we can avoid these by modifying the technique. Safety recommendations essentially have been ICES standards based on one physician's opinion. These recommendations were rejected by the Safe Use Initiative, even then approved by MPW, with no evidence or consensus, without even knowledge of their own membership. Consequently, we request that the warning be withdrawn and the 17 recommendations or regulations also be withdrawn. Thank you.
Thank you. Will speaker number 2 step up to the podium and introduce yourself? Please state your name and any organization you're representing for the record.
Yes, I'm the speaker number 2 again. I'm the chairman of the board of American Society of Interventional Pain Physicians. No conflicts of interest.
We don't have any slides for speaker number 2. Did you submit them?
Yes, sir.
I'm afraid we don't have any slides.
Okay. Well, in simple terms, the FDA's mission is to protect the public health and provide continued safety by following accurate scientific information. Recently, FDA Commissioner Dr. Hamburg stated that very real medical needs of the estimated 100 million Americans living with chronic pain is a major public health problem in the United States. This, we believe, that is a very inaccurate statement, unfortunately, based on the data from Institute of Medicine, as we have seen. Generally, patients presenting to interventional pain management are extremely chronic. We are not treating patients 6 months of pain. They have suffered for years, and they also have tried all other modalities of treatments. So they are not going to get better on their own. But all treatments are risky. For example, there are 1,000 deaths just for Tylenol, 17,000 deaths per year for non-steroidal anti-inflammatory agents, 17,000 deaths in 2011 for opioids. Of this, 4,500 just for methadone for 2% of the opioid prescriptions. Surgery itself can contribute to 1,300 deaths in 2008. In contrast, for epidural injections, there were 131 major complications with 41 cases of arachnoiditis. Without minimizing the impact of suffering and human toll of the complications, it appears that over a period of 10 to 20 years, there were 10 complications and 2 deaths per year due to interventional techniques. Again, the evidence was extrapolated from cervical epidurals, transforaminals, to the remaining ones. That is only 2% cervical transforaminals. The FDA announcement states that there are universal risks with epidural steroids and a lack of efficacy for them. Neither of these statements is based on the evidence. The FDA is also in the process of accepting so-called safety recommendations from multi-society pain work group and implementing them as regulations. To avoid numerous issues of access and unnecessary regulations, ACIP has submitted multiple comment letters with signatures of 1,040 interventional pain physicians, also an official petition. There also have been almost 80,000 patient letters supporting epidural injections. Of these, almost 4,000 going to FDA. Now, we are requesting a modification emphasizing the off-label use of epidural steroid injections and their associated risks, which needs to be done, of course, mainly with cervical transforaminals and occasionally with thoracic and lumbar transforaminal epidural injections. A boxed warning is the strongest warning based on medical evidence. The Drug Safety Oversight Board correctly pointed out that potential for unintended consequences of proposed class warning for corticosteroids. Interventional pain management is a new specialty with about 4,000 members of our organization. And if you take all these other organizations and eliminate the number of members from ACIP, there are basically only 4,000 or less, not that many more. The effectiveness of boxed warnings is highly questionable. Now, as we have seen, antidepressant use has gone down with the boxed warning, but suicides have increased. There are so many warnings on opioids, but we continuously face increased levels of deaths. So, in summary, our issues are related to the warning itself, the process and methodology, 17 recommendations, development of the work group, the safe use initiative, and inappropriate development of the warning without evidence, consensus, or transparency. Thank you.
My name is Kenneth Candido from Chicago. I'm a clinical professor of anesthesiology at the University of Illinois College of Medicine, and I'm a chairman of the Department of Anesthesiology at Advocate Illinois Masonic Medical Center, and I'm presenting on behalf of Dr. Mahendra Sanapati. I've also published in the peer-reviewed literature more than 17 articles referencing the use of epidural steroid injections, including several that were prospective, randomized, and blinded, and I've actually published more total patients, respectfully, than all the anesthesiology members of the Safe Use Initiative, and I express my gratitude to them as well for this attempt at trying to improve safety for our patients. I would like to speak about efficacy. The efficacy assessed in the FDA document is inappropriate and insufficient, leading to incorrect conclusions. The FDA assessment of the efficacy of the procedures was based on marginal literature research, the exclusion of numerous high-quality trials and poor evidence synthesis, which led to inappropriate conclusions. As you well know, AHCPR levels of evidence show that evidence obtained from at least one randomized controlled trial provides a level 1B, whereas 1A requires evidence obtained from a meta-analysis of randomized controlled trials. Similarly, the U.S. Preventive Services Task Force grading of evidence classifies level 1 as evidence obtained from at least one properly randomized controlled trial, and level 2-1 as evidence obtained from one well-designed controlled trial without randomization. The American Society of Interventional Pain Physicians has been utilizing the Cochrane Group's best evidence synthesis criteria, which lists level 1 as evidence obtained from multiple relevant high-quality randomized controlled trials, whereas for level 2, evidence is obtained from at least one relevant high-quality randomized controlled trial. Thank you. In evidence synthesis, and so these are the levels of evidence, and this is the grading of the evidence. In evidence synthesis, it is extremely important to understand the study design types as well as the mechanisms of placebo and nocebo. Many of the researchers participating in the FDA have been misbranding the trials and calling placebo-controlled trials with an active agent branding as placebo, whereas pure placebo without nocebo effect involves injecting an inactive substance into an inactive structure. Both criteria must be met. The authors should always avoid nocebo. Proper placebo designs have been developed in the literature. It appears that instead of following IOM's principles of avoiding conflicts of interest, the group assessing for FDA, along with numerous other systematic reviews, instead followed the principles of prepossession, rationalization, vagary, and congeniality of conclusion, resulting in a lack of integrity. The evidence shows that cervical interlaminar epidural injections are supported by 4 high-quality trials and 3 moderate-quality trials without opposing trials, with thoracic interlaminar injections being supported by 1 high-quality trial. And there are a multitude of assessments for caudal epidural injections with 6 high-quality trials and 3 moderate-quality trials showing effectiveness, whereas there was 1 moderate-quality trial showing a lack of effectiveness. For lumbar interlaminar epidurals, there were 7 high-quality trials supporting use, whereas there were 3 high-quality trials opposing them. And by the same token, for lumbar transforaminal epidural injections, there were 5 high-quality trials and 1 moderate-quality trial supporting efficacy, and only 1 high-quality trial with lack of efficacy. For percutaneous adhesiolysis, high-quality evidence and effective trials were 5, and moderate-quality trials were 2, with no ineffective trials. Of course, in this assessment, we have utilized only the randomized trials with at least a 6-month follow-up. So in summary and conclusions, I believe that there is an abundance of evidence in favor of the use of epidural steroid injections by all routes of administration, including cervical, thoracic, and lumbar, by 3 routes, including the caudal route, the interlaminar approach, and the transforaminal approach. Thank you.
Good afternoon. My name is John Dombrowski. I'm a physician anesthesiologist and an active interventional pain medicine physician. I'm here on behalf of the American Society of Anesthesiologists, a 53,000 member organization representing the largest number of practicing pain medicine physicians and recognized national leader in patient safety. I also serve on the board of directors for the ASA. ASA is extremely concerned that the FDA warning label issued on April 2014 fails to differentiate between the risk and the benefits of transforaminal interlaminar routes of administration and particulate and non-particulate formulations of steroids. ASA recommends that the FDA retract the warning and replace it with one pursuant to the following principles. 1. A black box warning is not appropriate for steroids injected to the epidural space. 2. A warning should be present for inadvertent vascular injections of particulate steroids via a transforaminal approach. 3. No warning should be issued for dexamethasone or other non-particulate steroids. 4, there is no indication for intrathecal steroid administration, and a black box warning would be appropriate in this context. We understand that International Spine Intervention Society and North American Spine Societies will be addressing the efficacy of transforaminal injections and the safety of dexamethasone. So ASA comments today will focus on the safety and efficacy of intralaminar epidural steroid injections. The evidence fails to establish a causal relationship between intralaminar injections of steroid medications and the development of death or paralysis. In fact, in my practice, over 20 years performing over 20,000 intralaminar epidural injections, no case of paralysis or death have occurred. The FDA is warning 17 references, none of which pertain to intralaminar epidural steroid injections. Reference 17 is the only review article cited by the FDA and actually lauds the relative safety of epidural block techniques. In that paper, Tony Wildsmith and colleagues conclude that the data are reassured and suggest that the epidural blocks have a low incidence of complication, many of which resolve in 6 months. Furthermore, in large-scale studies of epidural steroid injections, no major complications were identified, including those relevant to the FDA warning. In regard to their efficacy, intralaminar steroid injections are among the most often performed interventional pain medicine technique in the United States and have widely studied specifically in the lumbar spine with numerous guidelines, systemic reviews, randomized trial, observational studies. Utilizing high-quality randomized trials and appropriate methodological quality assessments of randomization trials with relative best evidence synthesized, utilizing grading of randomized trials. Level 1 evidence has been shown for managing disc herniation with epidural injections with or without steroids, but superior with steroids. Identification of evidence for spinal stenosis, post-surgical pain, discogenic pain has been level 1 to level 2 based on multiple randomized controlled studies assessed in systematic reviews. Epidural steroid injections are effective in well-selected patients, providing short-term benefit up to 6 months. The use of intralaminar steroid injections for the treatment of radicular pain is supported by good evidence of analgesic effectiveness. In recent published review, Pinto and colleagues conclude that high-quality evidence using grade classification systems exists supporting the use of epidural steroid injections to reduce pain and disability related to radicular leg pain, therefore providing level 1 evidence of effectiveness. Meta-analysis of these high-grade randomized controlled studies showed a significant reduction in pain and disability scores for 3 months following caudal or intralaminar injections. Given the low risk of epidural steroid injections and their benefit as a value treatment modality, ASA strongly recommends that the FDA retract the warning label. I thank you for your time.
Hi, good afternoon. My name is Ray Baker, and I'm here representing the International Spine Intervention Society. I'd like to thank the committee for an opportunity to speak with you on this important topic. I'd also, first of all, like to thank Dr. Rathmel for bringing some clarity to a very difficult and complex subject. I had the privilege of serving on the SUI along with Dr. Rathmel and chairing the Multi-Society Pain Work Group. And I can tell you, as most of you would know in this audience, it's difficult to impossible to get 13 medical societies to agree on anything, much less 17 recommendations for which he was able to bring consensus. So I applaud Dr. Rathmel for that work that he's done. I would also urge the FDA and the advisory committee to look at the DSB quote from 2010 when they looked at this subject, stating 2 things really. One is that we have to be careful for unintended consequences, and second, these are very complex procedures because of the injection technique and the location of injection, and they recommended at that time not placing a warning. To put this in perspective and to look about these unintended consequences, let's look again at the numbers that have been quoted today. Anywhere between 600,000, 9 million, whatever. There are a lot of these injections done every day. 10,000 per day was one quote. And yet there's only 134 cases in the FARS and 18 published reports. Granted, these are underreported and that the complication rate is higher than that. But I would also say the other complications are underreported from alternative treatments. I don't have the luxury of being able to sit across from a patient and say, no, I don't have a treatment for you. And if any of you have had severe lumbar or cervical radicular pain, you will know what I mean. These patients are in severe pain, and they will be on opiates, non-steroidal anti-inflammatory drugs, or receiving surgery. No matter what the natural history shows, it can be very severe pain. I also want to look at the complexity of this, and I'm not here to impugn the FDA report. I think they did an excellent job in a very difficult subject. I would say, however, that many of the cases were misattributed, and I just showed a few of them here. One was a case cited as a dexamethasone complication, and yet dexamethasone was mixed with methylprednisolone. You cannot attribute that to a dexamethasone complication. Another case was a stellate ganglion injection, again, not an epidural steroid injection. Another case, it was an epidural hematoma, not a methylprednisolone complication. And I could go on, but suffice it to say these are complicated. You need experts to look at this and really determine whether a complication is from the corticosteroid. And I would agree with the speakers before me that it has been difficult to separate out particulate from non-particulate. I'll say only this. We use the term particulate to mean a particle or aggregate size lower than a red blood cell. That's it. Capable or incapable of forming embolic phenomena. We are not chemists, so I apologize to the FDA that we did not use a proper term, soluble, but I would say that that was the intent behind these reports as they are. I would look at this and say that that led to the misattributing cases led to a statement that I think is incorrect, an association between catastrophic neurologic events and transforaminal injections of both particulate and non-particulate corticosteroids. With that, I would respectfully disagree with that FDA report. With the dexamethasone case, again, I'm not going to go into detail here, but an expert in interventional pain management would be able to separate these cases out that are clearly not steroid related, but much more likely to be injection related and needle related complications. None of them severe, by the way, and none of them catastrophic. Despite a lot of dexamethasone and particle-free corticosteroids being used across the United States, there has not been one single case of severe neurologic complication as a result of a non-particulate corticosteroid that has been shown to be the culprit in this problem. I would say that the SUI recommendations are to be followed. I think that it is a consensus of 13 medical societies, including neurological surgeons, orthopedic surgeons, radiologists, anesthesiologists, physiatrists, pain medicine specialists from across the board, and it would recommend that be heeded. We need to be aware of these complications that we might prevent them. My final conclusions would be that the FDA listened to the Safe Use Initiative, they would listen to their own DSB, and that corticosteroids are contraindicated in the intrathecal space. No warning should be applied to any non-particulate corticosteroid. No warning should be applied in the interlaminar technique to any corticosteroid. And the current FDA warning should be amended to include only particulate corticosteroids injected via transforaminal route. I appreciate your time. Thank you.
My name is DJ Kennedy. I'm a physiatrist at Stanford University and presenting on behalf of North American Spine Society. And we applaud the FDA for looking into this very important issue as indicated by the speakers before me. And we do agree with the recommendations of the FDA Safe Use Initiative and the Multi-Society Pain Work Group and feel that implementation of these guidelines will help not only increase safety but effectiveness of these injections. We agree with the multi-society letter to the advisory panel submitted by the International Spine Intervention Society that does go into more detail about the effectiveness of them. We also concur that corticosteroids are contraindicated in the intrathecal space, and we concur with our colleagues from the American Society of Anesthesiologists and the International Spine Intervention Society who have presented before me. We do, however, wish to make a couple of clear difference points from the FDA. First, the FDA classification of chemical property on solution versus suspension, not the commonly used particulate or non-particulate. This did result in 4 non-particulate steroids on the FDA list: beta-methasone phosphate, methylprednisolone succinate, hydrocortisone succinate, and dexamethasone phosphate. The FDA does list 4 complications related to beta-methasone. but in every instance, the betamethasone preparation involved used celestone, the commercially available property, which is a mixture of betamethasone phosphate and betamethasone acetate. And betamethasone acetate is listed by the FDA as a particulate, and I will show you why we feel this is important in a few minutes. And it is clear that none of the non-particulates on the FDA have ever been associated with a serious permanent neurologic event when used as a sole steroid agent. And none of the 3 additional steroids by the FDA on the non-particulate list have ever been listed in the FAERS report as having been associated with a serious complication. When we look at our commercially available, we have particulate methylprednisolone, triamcinolone, and betamethasone, and non-particulate dexamethasone phosphate. When we look at our light microscopy data of these, the mechanism of injury does become a little bit more clear. If you'll take a look at the slide by Derby et al., in the bottom right-hand corner, you will see red blood cells, and you'll see methylprednisolone aggregates to form clumps much larger than the red blood cells. The same is true with triamcinolone, and the same is true with betamethasone, which this is the celestone, which is the combination of the phosphate and acetate. This is in stark contrast to dexamethasone sodium phosphate. When looked under light microscopy, there are no visible particles, and the particles do not aggregate to larger than red blood cells. We also have 2 animal studies. One, the Okobadajo, who has been quoted here repetitively. The other one is Dolly. And we know that with particulate, significant neurologic compromise has been evaluated and seen every time a particulate steroid has been directly injected into an artery, as well as MRI showing brainstem edema and histology evidence of hypoxia and ischemia. This is in direct contrast to dexamethasone phosphate, which shows no neurologic injury, normal MRIs, and normal histology. Even when in the Dolly study, this was comparable to normal saline in the artery. We also have large cohorts of consecutive subjects. Over 16,000 consecutive epidural injections were done at the Mayo Clinic, Northwestern University, and the University of Pennsylvania. These were done by PM&R, radiology, and anesthesiologists, and practice patterns in accordance with the current MPW recommendations. And no permanent neurological injuries were reported in this entire cohort. We also, when we look at our dexamethasone and other non-particulates, they lack a biologic plausibility for injury based on light microscopy and animal data. There are no cases of injury in large consecutive cohorts, and there are no reported cases ever in the literature. Similar to antibiotics, not all corticosteroids have the same risk. The analogy here would be placing a routine warning on all antibiotics for tendon rupture due to this known association with fluoroquinolones. We also know corticosteroids are effective. We have over 25 outcome studies to date, both explanatory and pragmatic, and this is for lumbar transforaminal alone. We find lumbar transforaminal epidural injections are highly effective for treating radicular pain due to disc herniations and are surgery sparing. The negative reviews and studies inappropriately combine diagnostic and etiologies. Disc herniations do not have the same treatment effectiveness as spinal stenosis, failed back surgical syndrome, or epidural lipomatosis, all of which have been studied. The analogy here would be looking at a systematic review as if antibiotics are effective for cough. If you combine bacterial pneumonia with viral infections, COPD, and asthma, you will inappropriately conclude that antibiotics are not effective for bacterial pneumonia, which they are. In conclusions, epidural corticosteroids are effective when performed in appropriately selected patients. Dexamethasone is inherently safe, and any warning based on this medication would not be justified based on current evidence. And we encourage the FDA to not inappropriately label these medications and potentially limit patients' access to this effective treatment. Thank you for your time.
Specifically, cervical transforaminals are associated with a high risk with no efficacy. However, we are translating all the information from cervical transforaminal epidurals to everything else. In contrast, lumbar transforaminals are associated with moderate risk but with efficacy. Cervical, thoracic, and lumbar interlaminars, as well as caudal epidurals, are associated with low risk with efficacy. Multiple studies, including the one by ISIS, following their own standards, have shown a very low complication rate of 0.1%. However, without... Good afternoon. I'm Dr. Manchikanti. I'm the chairman of the board of American Society of Interventional Pain Physicians. I'm speaking on behalf of Dr. Bryce. I do not have any conflicts of interest. The FDA launched a Safe Use Initiative on November 4th, 2009. Since then, it has gone through several phases. The Safe Use Initiative rejected 20 recommendations, which are essentially the standards of International Spine Intervention Society. Even then, the FDA made safety and efficacy announcement in April 2014. Following this, the Multi-Society Pain Work Group approved 17 recommendations. We have major concerns in reference to the evidence standards applied here. The Institute of Medicine has developed 8 standards to be followed in the development of guidelines. In fact, studies show that majority of the clinical practice guidelines have not followed these 8 IOM standards, and IOM itself followed only 2 of the 8 standards and failed to follow 4 of the 8 standards. This is also evident with misrepresentation of evidence on chronic pain. We keep quoting that prevalence is 100 million and it costs about 635 billion. However, this estimation includes the joint pain, arthritis, and functional disability leading to that high number. Moderate and severe pain is only approximately 21%, costing about $100 billion. This is a large number, of course. There are multiple risks and complications associated with some of these procedures, as we have seen. Following ICE standards, we have shown a 0% complication rate in 150,000 patients. The mechanism of injury of complications with transforaminal epidural injections probably is misinterpreted. It has always been stated that embolism of the particulate steroid is responsible. However, as we have seen from the data, a similar proportion of complications also have been reported with non-particulate steroids. Consequently, the argument about the use of non-particulate steroid may lead to false sense of confidence without increasing safety. Now, as we have seen, it is impossible or extremely difficult to avoid